Hello, everyone. Thank you for joining today's MACRA Cost Measures Post-Field Testing webinar. The purpose of this webinar is to provide an update on the development of the 11 episode-based cost measures and 2 revised measures that underwent field testing in October to November of 2018. Now, I will turn the call over to Joel Andrus, Health Insurance Specialist in the Center for Clinical Standards and Quality at CMS. Please go ahead, sir.
Thank you very much. Good afternoon, ladies and gentlemen, and welcome to our MACRA Cost Measures Post-Field Testing webinar. My name is Joel Andrus. I am the Cost Measure Development Lead here at CMS. And was just noted, we'll be discussing today an update to the cost measures that we've been developing over the course of the past year and that we field tested in October 2018. We'll be providing not only a discussion of the process and the feedback that we've received, but also the implications for the measures as we've worked toward finalizing them. Can we go to slide 3, please? On slide 3, you'll see a list of acronyms used throughout this presentation. As federal employees, we tend to live and breathe these, but we also recognize that they can become confusing if you don't happen to deal with them on a daily basis. So we hope you'll find this resource useful. Slide 4, please. Thank you. On slide 4, you'll see our agenda for today's webinar. First, I'll be providing a brief overview of the development project to date, as well as the life cycle of these measures in the near future. After that, we'll be providing an in-depth review of the measures that were under development in the past year. That includes not only the 11 episode-based cost measures that we worked on, but also 2 total cost measures that we have revised extensively, the total per capita cost measure and the Medicare spending per beneficiary clinician measure. After we've presented the measures to you, we'll have an opportunity to field questions from the audience while we're on the line today. You can go to slide 6, please. Thank you. The MIPS cost category is one of 4 domains that CMS currently uses to calculate the MIPS composite performance score and constitutes 15% of the final score as of 2019. In 2019, the cost measures in the cost category included the MSPB and the TPCC cost measures that had previously been introduced into the program. CMS also expanded the category by introducing 8 episode-based cost measures. While the MSPB and TPCC are total cost measures accounting for costs associated with acute hospitalizations and primary care, respectively, the episode-based measures are more tightly focused on costs associated with specific episodes of care, including medical care and surgical procedures. We are continuing to develop episode-based cost measures to cover a broad assortment of care that constitutes a substantial portion of Medicare spending for Part A and B, with the intent of assessing clinicians as granularly as possible on the cost of care provided to patients. Clinicians should be held accountable for the care and costs that they are reasonably in a position to influence for the better. Slide 7, please. Thank you. Beginning last year, we initiated the development of an additional 11 episode-based cost measures with the intent of eventually considering them for use in the MIPS program. These measures were intended to extend the coverage of the episode-based cost measures to a more diverse set of clinicians in patient care. We also undertook the reevaluation of the 2 existing total cost measures in the program, the MSPB and the TPCC, in response to stakeholder concerns that we'd received about the measures. As with all of our cost measures, these measures were then developed using extensive input from a variety of clinical experts operating in focused work groups, as well as our Person and Family Committee, and through public comment collected following extensive field testing. Slide 8, please. The experts on the clinical subcommittees working with us identified 11 episodes for which they believe new cost measures could and should be developed. These measures included the acute kidney injury requiring new inpatient dialysis, elective primary hip arthroplasty, femoral or inguinal hernia repair, hemodialysis access creation, inpatient COPD exacerbation, lower GI hemorrhage, lumbar spine fusion for degenerative disease, 1 to 3 levels, lumpectomy, partial mastectomy, and simple mastectomy, non-emergent coronary artery bypass graft, psychoses or related conditions, and renal or ureteral stone surgical treatment. These clinicians also assisted us with significant input for the extensive revision of the MSPB and TPCC measures. Next slide, please. Field testing for these 13 measures was conducted in October 2018. We provided field test reports to clinicians nationwide, as well as draft measure specifications and supplemental documentation, with the intent of soliciting feedback from the community. Through the course of the month of field testing, we had more than 20,000 field tests downloaded by the community, and we received extensive feedback for the measures, which we then took into consideration at the measure level. Next slide, please. Having completed this, we provided the feedback to the expert work groups and the technical expert panel with whom we'd been working to develop the original draft specifications. The work groups and the TEP then recommended refinements to each of the 13 measures, which were then presented to the Measure Application Partnership in December of 2018 and January of 2019. Next slide, please. The Measure Application Partnership, or MAP, recommended conditional support for 10 of our episode-based measures and the revised MSPB measure. The MAP did not support the implementation of the episode-based measure for psychosis and related conditions. The MAP also did not support the implementation of the revised TPCC measure, but recognized potential for mitigation of their concerns in the future. Slide 12, please. We are currently in the process of reviewing the feedback that we received for the MAP and from other stakeholders, with the intent of finalizing the specifications for the 13 measures. We'll note that while the MAP did provide conditional support for our measures, they made that support conditional upon the endorsement of those measures by NQF. While we have not yet submitted those measures for endorsement, we plan to do so in the future. We also intend to post a report of our field testing results in April, which will be accessible through the link provided here at the bottom of the slide and later in the presentation. Next slide, please. As with our other measures, these cost measures are intended to undergo a standard 3-year maintenance cycle. What that means is that even though we'll be finalizing the specifications this year, we fully intend to be reevaluating those measures over the next 3 years. And that becomes important with the next issue that we're going to be discussing, which is your feedback and participation within this process. While we do designate field testing, for instance, as a specific time frame through which we're incorporating feedback from the community into these measures, the reality is that we've made available the mailboxes at the bottom of the slide explicitly for the purpose of receiving ongoing input from the community. And so we certainly invite you to provide us with that input. You're not simply limited to the periods that we've designated for field testing. And we take that input into account as we reevaluate the measures over the course of their life cycle. Next slide, please. Thank you. We anticipate that we will continue to develop additional cost measures for the foreseeable future. And as such, we want to make available to you information about the ongoing opportunities to participate in our development process. As I've noted here already in the presentation, much of our development process depends heavily upon the input that we receive from the community, either in the form of technical experts, through field testing, or through public comment. And so we certainly encourage all of you to participate in these processes to the maximum of your interest. We just recently sent out our call for nominations for participation in our clinical subcommittees that will be assisting us with the development of our Wave 3 measures, including, for the first time, chronic care episodes. You can reach out to us at the below emails if you'd like to know how to nominate participants in these panels or to self-nominate and participate yourself. Additionally, the Measure Application Partnership offers an opportunity annually to provide public comment regarding the implementation of measures we are considering for our program. And of course, as we take measures through the rulemaking process, you also have the opportunity to provide us with your input, and we encourage you to take advantage of that opportunity. Reaching out to us through our mailbox also allows us to consider your concerns through our annual maintenance process, as I mentioned earlier. And as we take the measures through the NQF endorsement process, they also provide an opportunity for the community to comment on the appropriateness of the measures. Taken in combination, this gives you an extensive opportunity to participate not only in the initial development of the measures, but also to react to the final product that has been developed through our process, and also to ensure that as the evidence base and the data evolve, that you're able to continue providing feedback to us as we attempt to keep our measures up to date and appropriate for our programs. Next slide, please. Now that we've talked a little bit about the development process under which all these measures are developed and maintained, I'm going to turn the presentation over to Dr. Nagavarapu, the project director for the team responsible for developing and testing these cost measures, so that he can present the revisions to the TPCC measure. Thank you.
Thanks, Joel. This is Sri Nagavarapu from Acumen. So we'll start off by walking through the revised TPCC measure, and then I'll hand it over to my colleagues here, Sam Bounds, to talk about the revised MSPB measure, and then we'll have my other colleague, Sam, speak to the episode-based cost measures. So what we wanted to do was start off with some very brief background on the total per capita cost measure, the TPCC measure. So the current version of the TPCC measure that's currently used in MIPS was introduced for use in the calendar year 2017 performance period. The current TPCC measure has been a part of the cost performance category since that performance period. Prior to MIPS, CMS had used a version of this measure in the value modifier program that some of you will be familiar with, and it's been reported in the annual quality and resource use reports, the QRURs. After MACRA ended the VM program, the TPCC measure was added to the MIPS cost category for a variety of reasons, and some of those are listed here. The hope was that the TPCC measure would provide an important measurement of clinician contribution to overall costs with a focus on primary care, chronic care management. The TPCC measure now has been revised with the revised measure being considered for potential use in MIPS in the future. And these refinements have focused on a few areas. Two are noted here. One, better identifying a primary care relationship, and two, allowing for multiple clinicians or clinician groups to be attributed responsibility to allow for a focus on care coordination. And we'll walk through other aspects of the refinement shortly. Next slide, please. So we wanted to give you a basic sense of the timeline that was used in constructing this revised version of the TPCC measure that we're discussing now. In August 2017, we have a standing technical expert panel for this project on cost measures that's been providing their expertise for a long stretch of time, providing strategic guidance on the development of cost measures as well as the revision of existing cost measures. In August 2017, that TEP provided some initial input on the direction of refinements for TPCC, as well as MSPB, which we'll talk about in the next section. They suggested focusing on attribution and service assignment, or which costs are included. In May 2018, we asked the TEP to focus more specifically on attribution, since the total per capita cost measure is by its nature a measure concept that's focused on total costs. But we did focus on their feedback to revise attribution in a number of specifically, their guidance was to have refinements that should focus on identifying the start and end of a clinician's primary care responsibility for a patient, and account for the shared responsibility across clinicians in cases where that occurs. we took that input and put together a series of revisions to the TPCC measure, focusing on attribution, but refining other aspects of the measure as well, which we'll walk through briefly. And then put together reports for the full set of attributed clinicians for the TPCC measure, and field tested the revised measure in the October to November 2018 period. During that time, we tried to get the word out through education outreach activities, holding office hours for relevant specialty societies and the webinar, and trying to encourage people not only to download the reports, but even if they didn't receive a report, to download the mock reports from the CMS website, look at the measure specifications, and provide feedback on all aspects of the measure, ranging from the actual specifications and the changes to the attribution rules and so on, all the way to the way that the measure specifications are presented, whether they're clear enough, whether they're comprehensive enough, and then the way feedback is given and whether it's actionable. We took that feedback from field testing that we received from stakeholders, consolidated it, and took it back to the TEP in November 2018 to ask a range of questions that were motivated by the comments we got during field testing. And a lot of that discussion focused on the attribution question of whether certain types of specialties should ever be considered for attribution in TPCC. And we got a lot of useful feedback from the TEP about that, also reviewed the comments we received in field testing and afterwards, and then made adjustments to the measure accordingly to exclude a whole class of specialties from being attributed the measure if they're unlikely to be involved in any sort of primary care management. Next slide, please. So before diving into the details of the measure specifications, what we wanted to do is give you just a very high-level comparison of the current TPCC measure and the revised TPCC measure along some salient dimensions. First, you'll see in the first column the current TPCC measure and the basic features of that measure, and then in the row in the second column, you'll see the change that was effectuated for the revised measure. So walking through these very quickly, and we're happy to answer questions about these in more detail in the Q&A session. First, the triggering or the initiation of a relationship between a clinician and a beneficiary can be based on the plurality of ENMs in the current TPCC measure. What I mean by that is that the beneficiary is attributed to the clinician who provides the largest share of ENM costs during the course of the performance period. And the ENM costs are what we'll call primary care ENMs. Really, those are ENMs that are typically offered in an office setting or an outpatient setting. The revised TPCC measure changes this to try and address the fact that previously there could be just one ENM that triggered a relationship in the current measure. What the revised TPCC measure does is triggering a relationship between a beneficiary and a clinician requires not only a primary care ENM, but also a confirming event. And by a confirming event, I mean an additional primary care ENM that occurs in that 10, or a primary care service that could include certain diagnostic tests, lab tests, and so on. The second dimension, and I'll walk through the rest of these more quickly, is that in the current TPCC measure, cost could be assigned to a clinician, to an attributed clinician, prior to their seeing a beneficiary. In the revised TPCC measure, this is something we wanted to address after discussing this with the TEP extensively. And cost in the revised measure is only assigned to a clinician after seeing the beneficiary. And we'll walk through an example of this in the coming slides. The third row there looks to attribution. The current measure tries to single out one TIN NPI, or clinician, for attribution. The revised measure allows for multiple attribution to TINs and TIN NPIs to account for the fact that there may be multiple clinicians involved in the care of a single beneficiary and to help incentivize care coordination. The current TPCC measure has a rule where primary care clinicians, and we can talk about exactly which specialties those are, but primary care clinicians are given precedence over non-primary care providers in attribution. The revised TPCC measure actually excludes certain non-primary care specialists and clinicians that are providing a lot of non-primary care service, and we can again get into the specifics of this. But it excludes them from the possibility of attribution. The current TPCC measure uses risk factors for risk adjustment that are determined in the calendar year prior to the measurement period. The revised TPCC measure is a measure that, instead of looking at the whole performance period, is averaging risk-adjusted costs across months or beneficiary months, a month for each beneficiary. And the risk factors are actually determined 1 year prior to each of those months. And so what that allows for is that if a clinician picks up care of a beneficiary halfway through the year, for instance, that you're accounting for all the comorbidities that beneficiary may have picked up all the way to the point that clinician initiates the relationship with the beneficiary. In the next row, the current TPCC measure has 2 risk models for new enrollees and community model. The revised TPCC measure expands this to include CMS's institutional model to try and better account for those who spend a significant fraction of time in the nursing home setting. And then finally, the current TPCC measure has an annualization of costs for beneficiaries. What we mean by that is if there's a beneficiary who passes away after 6 months during the performance period, their costs are doubled in order to inflate them to a full 12 months. Whereas the revised TPCC measure can be more flexible because it's focusing on costs on an average monthly basis. And simply what happens here is that there's no grouping of costs for months after a beneficiary's death. Next slide, please. So what we wanted to do is, and I'll go through the remaining slides here pretty quickly, is just give you a little bit more detail on each of these changes with a couple diagrams to hopefully help understanding. This slide walks through the step-by-step calculations of the measure. The first is triggering candidate events by identifying a primary care E&M service with a confirming event, as I mentioned before. That's what determines the initiation of a relationship between a clinician or clinician group and a beneficiary. The second is to apply the exclusions that we talked about, to try and exclude specialties who are very unlikely to be doing any primary care management. The third step is to initiate a year-long risk window from that point in time when the relationship starts, and then attribute beneficiary months that occur in that risk window and occur in the performance period. And we'll show you a diagram to make this a little bit clearer. The fourth step is to calculate payment standardized monthly cost. By payment standardized, what we mean here is cost that is standardized to remove geographic variation and other policy-induced variation in Medicare payment rates. The fifth step is to risk adjust to account for beneficiary level risk factors, as we talked about briefly. The sixth step is to apply a specialty adjustment. This accounts for differences in costs that are inherent to different clinical specialties. And then the last step is to calculate the measure score. And what you end up getting is the average or mean payment standardized, risk adjusted, and specialty adjusted monthly cost for attributed beneficiary months. Next slide, please. So we wanted to kind of briefly provide a diagram here. But what you'll see in the diagram is that in the blocks that are in the measurement period, you'll see a total of 13 of those blocks. So there are 13 4-week periods that make up 1 year for a performance period. In the example, you see 3 triangles. 1 yellow triangle for Clinician B. Let's say that's 1 primary care E&M service. And then 2 gray triangles, 1 for Clinician A for a primary care E&M service, and then a second primary care E&M service from that same clinician a short while later. The way the TPCC measure works is, in this case, the rule will initiate a relationship to indicate that Clinician A is managing the beneficiary, because you see 2 primary care E&Ms, a single primary care E&M plus a confirming event within a 90-day span. And then a year-long risk window is initiated. That's what you see at the bottom there. What this is the period of responsibility for costs for Clinician A. The months that are counted in the measure are the ones that are in blue here. And the thing you'll immediately notice is that the only months where costs are counted in the measure and average to create Clinician A's measure score are only those months that show up in the performance period or the measurement period, which could be you could think of as the MIPS performance period. So the only costs that are counted are for months that are in that year-long risk window and show up in the measurement period. Next slide, please. So this gives you an illustration of one of the salient differences between the current TPCC measure and the revised TPCC measure, using analogous sorts of pictures, as you just saw. First, let's take a look at that top diagram there. Again, you have a measurement period. At the bottom there is indicated that it's a TPCC episode window for the current TPCC measure. All that is 1 year for the current TPCC measure. It's just the calendar year for the MIPS performance period. So what you see here is that Clinician B has 1 triangle that indicates 1 primary care E&M service. Clinician A has 2. And the way that the current TPCC measure works is that the total year of costs for the beneficiary is allocated to the clinician that has the highest fraction of E&Ms. And so in this case, the total year of costs, all those blue boxes there, are going to be allocated to Clinician A. And so you'll see right away that an issue that has been raised in the past about this is that there are months of cost there that occur before Clinician A has started seeing the patient that will be allocated and attributed to Clinician A. The revised TPCC measure tries to address this. And the way it addresses this is depicted in this bottom box here. The triangles are positioned in exactly the analogous way. Here, Clinician A has 1 primary care E&M service, and they have a second confirming event that happens within 90 days. So that initiates or triggers the relationship between Clinician A and the patient. However, the risk window only opens up a year from when that relationship starts. And so that's what you see at the bottom there, that the risk window starts at that first blue triangle and then goes for a year. And then only the beneficiary months that appear in the risk window and during the measurement period or performance period are counted in the measure. That's why you see that only those 3 blue or green rectangular boxes there are counted, and not the next one over. The very last one is still gray because it's not in the measurement period or the performance period. We've gotten questions about this, about what happens to that last gray box, and the quick answer to that is that in the next measurement period for MIPS, that gray box will be counted in average costs for that measurement period. But only those blocks or months that are in the measurement period and in the risk window are counted for costs for this particular measurement period. And right away what you'll see is that no costs prior to the clinician A seeing the beneficiary are counted in clinician A's measure for that measurement period anymore. Next slide, please. So what we wanted to briefly summarize, and we can go through more details in the measure, but we just wanted to give you a sense of what's happened through field testing and after field testing here before we get to the Q&A period. So the revised TPCC measure during field testing excluded clinicians based on certain service category exclusions or based on the types of services that they did for beneficiaries. And so if you're performing global surgery claims or procedures or therapeutic radiation, chemotherapy, or anesthesia for beneficiaries, you were excluded during the field testing as long as you did that often enough for your beneficiaries. The revised TPCC measure after field testing, using the refinements from the comments we got, added additional exclusions. And so there's additional specialties that are identified by what we'll call the HCFA specialty code, that's self-reported specialty. And clinicians who belong to any of those identified specialties who are not reasonably responsible for primary care were also excluded. And this was based on comments we received in field testing as well as discussion with the tech. The next area is risk adjustment. In the revised TPCC measure during field testing, we didn't include specialty adjustment. This was mainly to focus on all the other measure refinements that were going on and to try and avoid confusing the issue. But one of the comments we got during field testing and afterwards was people very much felt the specialty adjustment was important. So we've placed the specialty adjustment back into the measure, and the refined version of the revised measure has a specialty adjustment in it to account for inherent differences across specialties and costs. Next slide, please. We wanted to briefly summarize sort of what we've been able to address and what's left over as concerns of the revised TPCC measure, as well as provide some clarifications about that. So the first is that all cost measures tend to hold clinicians accountable for costs that are outside of their control. Here, the concept of the total per capita cost measure, the intent is to capture the overall cost of care as a broad population-based measure. We will be talking about the MSPB measure and the episode-based cost measures next, which provide more refined views of what costs can be counted in a measure and complement the TPCC measure. The second is that the measure is overly complex. This is something we're definitely sensitive to, and the plan is to hold additional education and outreach activities in order to explain the measure. I should note that the complexity of the measure comes from the desire to address stakeholder feedback about problems with the measure, and so we've tried to address those problems in as simple and targeted a way as possible. That has increased the complexity of the measure in certain dimensions, but we believe that the trade-off is a more valid and compelling measure. Third is the need for further testing and stakeholder input. I should note we've conducted very extensive testing for validity and reliability, and we're glad to be sharing those results as we go along. We'll be releasing an updated national summary data report. The mean reliability of the measures are high. We provide a range here depending on various assumptions you can make about reliability, and even regardless of assumptions, the mean reliability is high. And if the measure is in the future proposed for use in MIPS, in that case, if that happened, then there'd be possibilities of further public comment. The fourth item here is that the new attribution approach expands attributed clinicians too extensively. The the important point here is that confirming E&M or other primary care services always have to be present to initiate attribution. The reason for the multiple attribution is to try and focus on care coordination for patients, trying to be cognizant of the fact that patients may have multiple clinicians that are managing their care simultaneously and sharing responsibility. What we can walk through or note results that show that the attributed TINs and NPIs on their measure actually perform a large share of E&Ms for attributed beneficiaries to help support the validity of the attribution rule. Finally, there's a question about double counting of costs and beneficiaries with episode-based measures. It's critical to note here that there's no double counting here because each measure is comparing costs that are observed to expected costs for their own beneficiaries or episodes. So this isn't an exercise in which any single dollar that's paid is trying to be allocated to one measure or the other. Instead, what this is doing is comparing observed costs in each measure to expected costs given that beneficiary's comorbidities for that specific measure. And so double counting it isn't a concern. Now there is a program level decision about how the measures will be used in combination, but that's distinct from the design of the measure itself. Next slide, please. So we wanted to provide some basic summaries of a number of attributed clinicians. This is for the TIN-NPI version of the measure rather than the TIN version of the measure. And again, this is if clinicians are reporting quality measures as a group and reporting in MIPS as a group, they would get the TIN version of this measure. If they're reporting as individuals, they would get the TIN-NPI version of this measure. Here, this shows the TIN-NPI version of the measure and the attribution by specialties. One thing you'll note is that the total number of clinicians increases here from the current TPCC measure to the revised TPCC measure. This has to do in part with the multiple attribution of clinicians. But I should note that this number does not take into account certain restrictions that will affect who actually gets a MIPS composite score. So for instance, this number is for all clinicians and doesn't take into account which clinicians are qualifying participants for advanced APMs, for instance. And the reason for this is that in the testing that we're showing you here and have been doing on the measure, we don't want to have results that prejudge who will be in advanced APMs versus not, and want to make sure that the measure is a valid and reliable measure for the full extent of clinicians. The other thing you'll notice is that certain clinicians have their counts go to 0. This has to do with the exclusions of particular specialties from attribution. Next slide, please. Here we briefly walk through the performance on the TIN version of the measure by practice size. The thing you'll note is that reliability tends to be very high and that there don't seem to be very systematic differences in performance across practice size. Next slide, please. And then just to conclude here, real quickly, so the TPCC measure here is tended to meet a very specific program goal of a population level measure. And what we've tried to do with the revised TPCC measure is address as many of the stakeholder comments that we've seen beforehand and during field testing as possible. And the measure has gone through an extensive set of testing. We're happy to continue answering questions about it to provide sort of a window into aspects of the measure specifications people may find that they have questions about. Okay, great. So I'll turn over the presentation now to the next section. Next slide, please.
Thanks, Sri. So for the next section, we're going to be going over the revised modifications to the revised MSPB clinician measure. Next slide, please. So the MSPB history and measure revision timeline largely parallels that for TPCC. So this should look familiar to what we just went over for TPCC, but just as a refresher, the MSPB measure has been in the MIPS cost performance category since 2017 and continues to be. Prior to its use in MIPS, it was in the Value Modifier Program, or the VM program, and reported on the annual QRURs. As MACRA sunsetted the VM program, MSPB was adapted for its use in MIPS, given its familiarity with clinicians and its ability to provide impactful information to clinicians on their cost to overall Medicare spending, with the focus on the inpatient setting rather than the primary care providing setting that the TPCC is focused on. So in current upkeep with the measures that are included in the MIPS, CMS will continue to revise these measures, and we'll go through those revisions today. And primarily, there's two broad areas of revisions that we've made for the MSPB measure. The first is how we attribute clinicians responsible for beneficiaries in the inpatient setting. And secondly, what costs we assign to those MSPB episodes that we feel are reasonably influenced by the attributed clinician. Next slide, please. So this next slide shows the measurement development process for the revision of MSPB clinician measure. And as you can see, the TEPs in August 2017 and May of 2018 align with the process of TPCC. In this first TEP, we got general guidance on where we should focus our revisions, taking in input from the TEP and also public comment we received on the measures. When we reconvened in May of 2018, we pinned down specific action items of how to address these revisions. So specifically, how are we going to attribute these episodes? And we'll go into detail on how those revisions look in a couple more slides. And also refinements to what services are assigned to MSPB episodes cost. And so in this third column here, we have the MSPB Service Refinement Work Group. This was a special development step for MSPB specifically at the recommendation of the TEP. In order to address this revision of what costs could be removed from episodes that is unlikely under the care decisions of the attributed clinician, they gave us recommendations on how to address this problem and how to define these rules. And so also recommended we convene a separate work group to evaluate and define these rules. And so in June and July, we convened a group of 25 clinicians from a wide range of specialties to help us define rules at a major diagnostic category. So as we'll see in a couple of slides, the MSPB episodes are based on an admission to an index hospital. And the MSBRG of that index admission can be categorized into one of these major diagnostic categories that characterizes the clinical area in which it's relevant to. And so to curtail the service exclusion rules or what services should be removed from which episodes, index admissions were aggregated in such a way that the rules could be customized to different clinical areas, so they're more relevant for what is feasible and reasonably under the control of the attributed clinician and what's not. After implementing these revisions, we field tested the revised measure in October and November 2018 along with TPCC and episode-based cost measures. And then to close the loop, circled back with the TEP in November after field testing to see how they thought these revisions panned out. Next slide, please. So this next slide just gives a high-level refresher on how MSPB episodes are constructed and how they're used to calculate a clinician's measure score. Right here we're outlining the steps for the revised MSPB clinician. So first we'll identify episodes as an admission to an IPPS hospital. So we're focused on inpatient care. We'll exclude episodes if beneficiaries are not continuously enrolled in Part A and B. Secondly, we'll attribute the episodes to the clinician that we feel is responsible for the patient's care. And so this step 2 right here is one of the first major areas of our refinements. In step 3, we'll aggregate the costs during the episode window 3 days prior to the index admission and 30 days post-discharge. With our second main revision of excluding some services from cost assignment that are unrelated to the DRG of the admission. The next couple steps are similar to the current MSPB clinician measure being used in MIPS currently. So that episode cost will be risk adjusted to take into account factors, differences in beneficiary characteristics pre-existing to when a clinician has seen the patient. And then lastly, we'll calculate the measure, essentially looking at the ratio of how much cost was grouped to an episode or the observed cost in relation to the expected cost predicted from risk adjustment. This ratio would be averaged across all episodes attributed to a clinician to essentially give your measure score, and then we multiply that by national average observed costs to scale this ratio into dollar figures. Next slide, please. Here's a visualization of what an MSPB episode would look like. So we're focused on inpatient care. So if we look at the largest turquoise triangle, that is the admission to the IPPS hospital, and then the turquoise bar is the duration at which they're in the hospital. To make up the complete episode window, we're going to look at 3 days pre-admission to this index admission to look for services prior to surgical MSDRGs or diagnostic work or checkups prior to planned admissions. And then post-discharge for 30 days, we'll also observe costs for any outcomes or follow-up visits. In aggregate, this will make the total MSPB clinician episode window, which will evaluate for and cost for the clinician. If you look at the smaller triangles, the blue ones here are indicating services that will be grouped to the episodes, while the white ones are indicating one of our revisions and that some select services that we deem unrelated will not be grouped to the episode cost. Next slide, please. So here we have a table that outlines the differences between the current MSPB and the revised MSPB clinician measure. And we can go into more detail on how each one of these changes came about and what the current result is. So the first 3 bullets are really related to attribution. So one of the stakeholder comments that we got for the current method in use is the current method in use is attributing the single tenant PI that's billing the plurality or the majority share of Part B physician and supplier or carrier claim costs rendered during the inpatient admission. So we're looking for the clinician essentially that has spent the most PV costs during the index admission. Some of the stakeholder feedback was concerned with this attribution method or thought it didn't fit all admission types in that a clinician could be attributed for providing maybe one very expensive service, but is not necessarily responsible for the overall care continuum of the beneficiary. For example, like expensive diagnostic services. In related to the current MSPB attribution method, this also results in attributing only a single tenant PI for a beneficiary or for an index admission. And it really focuses on finding the clinician first, or at the TIN MPI level rather than the TIN. And so a second comment or recommendation we got from stakeholders in our TEP is the need to encourage or look for team-based care that is often exercised in the inpatient setting. So to contrast this attribution method with the revised measure on our right side, the TEP thought it apt to actually have separate attribution methods for medical and surgical episodes. Medical episodes are defined as index admissions with medical MSDRGs, where surgical episodes are defined as index admissions with surgical DRGs. And so for medical episodes, we're actually firstly going to look for the TIN rather than the individual clinician, to look for the team that's responsible for evaluating and managing this patient during their time in the inpatient setting. So for medical episodes, a TIN will be attributed if they have 30% of the evaluation and management codes billed during the index admission. And then to attribute to individual clinicians, we'll do that secondly for medical episodes. We'll attribute the episodes to any NPI under a TIN which was found responsible by the 30% E. For surgical episodes, we're actually going to look for the concurrent TPT or HCPCS procedure code that's related to that MSDRG and attribute the surgeons, both the TIN and the TIN NPI, that are billing those codes. These revisions to the attribution method allow for multiple TIN NPIs to be attributed under a single TIN and even multiple TINs, and encourage more shared and joint responsibility of patients during the inpatient admission. And then our second major revision is the exclusion of services unrelated to the index admission. In the current MSPB measure, all Part A and B claims paid during the episode window are assigned to the episode and the attributed clinician. Through our MSPB service refinement workgroup, alluded to a little bit earlier, they evaluated MSDRGs by groupings of their major diagnostic category to define rules in which services are unlikely related to the index admission, to remove some of the noise in the amount of cost that's assigned to an episode that might not be reasonably under the influence of the managing clinician during the index admission. So some examples of this is, for all episodes, hospice was excluded from all episodes. And then in a specific example, MSDRGs related to disorders of the gastrointestinal system, so the gastrointestinal MDC category, would exclude all orthopedic surgery or orthopedic procedure MSDRGs in the downstream, which are unlikely to be related. Next slide, please. So after making the revisions, we want to do diagnostic testing and show how the measure looks. Currently on the screen right now, we're showing the TIN version of this measure, and also giving a little bit more detail based on TIN size. The reliability still stays high for the measure, and the distribution of measure scores is not substantially biased for a TIN size. Next slide, please. So one of the ideas that was brought up by the TEP when we circled back after field testing was the idea of attributing TIN NPIs for the medical episodes. So as a reminder, for medical episodes in the revised version, we're going to attribute the TINs actually that are performing 30% of the evaluation and management codes. And then any NPI under that TIN billing one of those evaluation and management codes will also be attributed. And so here in this table, we wanted to follow up with the TEP and look into a more strict criteria for identifying the NPIs as individuals. And so in the first row here, we have the current rule that's used in the revised MSPB measure. So it's termed the TIN level 30% rule. And then in the second line, we're testing out applying that 30% evaluation and management threshold rule of claims billed during the index admission at the 10 MPI or the individual clinician level. And so when we compare these rules, we see that we get much more coverage with the first rule, which is rather intuitive, and really no reduction in the reliability of the measure. So there was some discussion on how much the joint responsibility of all NPIs under a 10 is, in terms of once we've identified a 10 responsible for the beneficiary, and we felt with no reduction to the reliability of the measure and the increased joint accountability, that this method was still valid. Next slide, please. So after the revisions, the MSPB clinician measure is still reliable, and testing has shown the reliability to be equivalent to the current MSPB measure, and it successfully addressed two of the major and most loudly heard stakeholder concerns regarding how episodes are being attributed to clinicians and also how cost is being assigned. By better identifying who's responsible during medical or surgical episodes, and then secondly, removing costs unlikely to be related to the index admission to remove excess statistical noise in the MSPB episodes. And if you'd like to dive into the measure specifications in more detail, these will be posted. The revised MSPB measure specifications will be posted on the MACRA feedback page next month. The next slide, please. So now I'll turn it over to Joyce to take us through the episode-based cost measures.
This is Joyce Sam. I work with Sri and Sam at Acumen on the episode-based cost measure development project. And so we're going to shift gears a little now to talk about episode-based cost measures. Next slide, please. So unlike TPCC and MSPB, which have been revised and updated through the measure reevaluation process, the episode-based cost measures that were field tested last year have been newly developed for this project. They also are clinically refined measures. So while the measure intent of MSPB and TPCC is to provide this broad picture of clinician performance, these measures are specifically tailored to conditions and procedures, either the condition itself or procedures to treat that condition. As such, they include the cost to Medicare for services and items that are furnished to a patient during an episode of care or instance of an episode group. These services are those which are clinically related to the treatment of the condition or the procedure and have been identified as being within the reasonable influence of the attributed clinician. So for example, these services would include not just the cost of the procedure itself, but could also capture pre-procedure testing, routine follow-up care, and consequences of care such as complications. And this is something that we'll go into with a diagram in a couple of slides. So our measure development approach gathers detailed clinical input on each aspect of these episode-based cost measures from a range of clinical experts through clinical subcommittees and measure-specific work groups. So far in the project, we've developed a total of 19 episode-based cost measures across two different waves. So in wave 1, which was in 2017 to 2018, we developed 8 measures. These are the 8 episode-based cost measures which are currently in use in the cost performance category for 2019 MIPS. In wave 2, we continued our measure development work and have completed development of 11 measures from 2017 to 2018, which underwent field testing last October and November, and which were reviewed by the MAP in December of last year and January this year. As Joel mentioned a little earlier, we are also currently starting wave 3 of measure development with a nomination period, which will include chronic condition episode-based cost measures for the first time. Next slide, please. So as I mentioned, we've developed 19 episode-based cost measures, so 6 acute inpatient medical condition episode-based measures and 13 procedural measures. As you can see, these cover a wide range of clinical areas and different specialties. For example, just to name a few, these measures could apply to gastroenterologists, orthopedic surgeons, psychiatrists, nephrologists, ophthalmologists, just to name a few. The work to develop these clinically refined measures requires a lot of targeted input from experts in these areas. Next slide, please. So this table will look familiar from the previous section, and it shows the systematic way in which we gather this detailed clinical input to develop the episode-based cost measures. First, we have the Technical Expert Panel, or TEP, which is a standing group of 19 members who have been with us since 2016, who provide strategic guidance both on measure development and reevaluation. We have then the Clinical Committee, which was convened in 2016, composed of over 70 clinical experts to provide input on the draft list of episode-based cost measures. This is the list that we use as a starting point for our cost measure development activities. Following the Clinical Committee in 2016, we have embarked on developing the episode-based cost measures through clinical subcommittees in the 2 waves that I mentioned before. So in wave 1, we convened 7 subcommittees comprising approximately 150 clinicians who developed the 8 episode-based cost measures. In wave 2, we made some changes to the structure based on feedback that we received from members. So we still have these broad clinical subcommittees representing a clinical area, and the input that they provide is to consider episode group prioritization to make a recommendation on which episodes develop. Following that, we compose a smaller targeted measure-specific work group of around 15 members to provide the detailed input on each component of the episode-based cost measures. And we found that this structure has worked really well in striking a balance between both involving a broad range of clinicians with experience in the clinical areas, as well as getting the very detailed clinical input and reviewing the analyses that we provide to develop each aspect of the measures. So as you can see also here that the scope of the work has grown, and in wave 2 we had over 265 clinicians involved at the subcommittee level to develop the 11 measures. Finally, here we have the Person and Family Committee, which has involved over 60 members throughout the project. And these PFC members have provided input through a series of in-depth interviews to provide guidance and share their perspective on episode group development. For example, the Person and Family Committee have highlighted principles which should guide the prioritization of measures to develop, such as the importance of developing measures that cover a large number of beneficiaries. Throughout the waves of development, the PFC has also provided more detailed input specific to each measure that's developed, engaging in this ongoing bidirectional conversation with the CS members. So for example, the members of the work group can ask questions to the Person and Family Committee for their specific input. This could involve gathering the patient perspective on services that they perceive as having helped recovery and when they feel like they have recovered from a particular course of treatment. Next slide, please. So this slide outlines the steps for construction of episode-based cost measures, and there's just a couple of things I wanted to highlight on this. So this includes the steps for both procedural and acute inpatient medical condition measures. So there are important differences in how we trigger or open an episode and how we attribute the episodes. So for acute measures, we trigger or open these episodes by looking at the inpatient stays as identified by particular MSDRGs. Whereas for procedural measures, we open these based on specific CPT HCPC codes, which indicate that a procedure has been performed. For attribution, for acute measures, we attribute to the TIN that build at least 30% of the evaluation and management or E&M codes during the triggered inpatient stay, and to any TIN NPI or individual clinician who builds at least one inpatient E&M code as part of that attributed TIN. So this is similar to what Sam was walking through for MSPB. For procedural episode-based cost measures, we attribute to the TIN NPI that builds a trigger code, being the specific CPT HCPC codes. For the next steps, we assign costs for the clinically related services, which we'll go through on the next slide with a diagram to calculate the observed episode cost. Next, we apply a set of exclusions to remove certain episodes. So these include exclusions for data cleaning to ensure that we have complete information for all the beneficiaries, as well as measure-specific exclusions to remove small groups of clinically distinct patients where meaningful comparisons can't be made with the larger cohort. We then risk adjust to account for patient factors. We use the CMS HCC model as a base and also add specific risk adjusters for that measure to account for particular factors outside of the clinician control. Finally, we calculate the measure score as the payment standardized risk adjusted average episode cost. Next slide, please. So this is what we affectionately call the triangle diagram, which illustrates the idea of this episode of care and shows the services which are included in the episode cost. So as you can see, the large teal triangle represents the trigger service, which opens or identifies when an episode has begun. From here, we establish a post-trigger period and a pre-trigger period, if applicable, to form the overall episode window. And within these periods, we identify particular services that are clinically related to that trigger procedure or that inpatient stay that are not just related, but also within the reasonable influence of the attributed clinician. So if we consider the example of, for example, a hip arthroplasty procedure, which opens this episode, we can consider that some of these dark blue triangles, which represent the services assigned to the episode, could be for pre-surgery imaging services in this pre-trigger period. And then in the post-trigger period could include follow-up care from the surgeon, as well as other services provided by other clinicians, for example, rehab services. So you can see all the white triangles here represent services that have not been assigned to the episode, which could be for unrelated services occurring during this time. So for example, if this patient gets hit by a bus, then these services would not be included as it would be outside the reasonable influence of the attributed clinician. Next slide, please. So this slide walks through the attribution for acute inpatient medical condition episode groups. So as we mentioned, they would attribute to TINs billing at least 30% of E&M codes during the trigger stay, and TIN NPIs billing at least one E&M code. So what these colored bars represent is the 9 E&M codes that were billed during this trigger stay. They were billed by 4 different TINs and 8 different clinicians. So if we consider each of these in turn, we can see who of these have been attributed this episode. So the first step, we consider which TINs have met the 30% threshold. Here, TINs A, B, and C have not met the 30% threshold, so they will not be attributed this episode. TIN D, however, has 56% of the total number of ENMs during that trigger inpatient stay, so TIN D will be attributed to episode. Now that we've established that TIN D is attributed to episode, we can move on to consider clinicians within that TIN, so clinicians 5, 6, 7, and 8. Clinicians 5, 6, and 7 each build 1 ENM, and clinician 8 build 2 ENMs. Since the rule that we use is that any clinician billing at least 1 ENM is attributed, all of these 4 clinicians will be attributed this episode. As you can see from these grayed out ones, since TINs A, B, and C did not meet the 30% threshold, the clinicians under them will also not be attributed. Next slide, please. So this slide just provides a quick summary of the attribution for procedural episode groups. Basically, we attribute looking at the CPT HCPCS codes on Part B physician supplier claims, and we attribute to the TINs and TIN NPIs billing that trigger code. Next slide, please. So as we mentioned earlier, we went through a field testing period during which time over 20,000 reports for episode-based cost measures, MSPB and TPCC were downloaded, and we received a lot of detailed feedback from stakeholders. We summarized that feedback and brought them back to measure-specific work groups to consider both feedback and testing that we continuously do throughout the development process to make additional refinements to the measure. We did this process for each of the 11 episode-based cost measures that were field tested, and this table just summarizes some of the changes that were made for one example measure. This one is the COPD measure. So as you can see, the work group considered the feedback to make some changes such as adjusting the subgroup, adding exclusions, and changing the service assignment rules. Next slide, please. So the next couple of slides are analogs to what Sam walked through for MSPB, and these give you a sense of some of the ongoing testing that we do for the episode-based cost measures. So this one shows an example of the femoral inguinal hernia repair measure, and it shows the performance broken down by TIN size and the reliability and distribution of measure score. So as you can see, it has a high mean reliability, which is quite stable across the different TIN sizes. Similarly, the distribution of measure score is fairly similar across the different buckets of TIN sizes we have. Next slide, please. Here we have a similar table for the COPD episode-based cost measure, so one of our acute condition episodes. And similarly, you can see the mean reliability at all TINs is high, and that the reliability for TINs of different sizes is also quite strong. Next slide, please. This slide shows some of the attribution analyses that we've done, similar to the one that we did for MSPB. So here we look at TIN NPI attribution using 2 different rules. So the first one, here, TIN level 30% rule, is the one that we currently use, where the TIN bills 30% of the inpatient ENM, and TIN NPI is attributed if they are within that TIN and bill at least 1 ENM. TIN NPI, 30% rule here, is the more restrictive rule. So this requires that the TIN NPI themselves must bill 30% of the ENM from the trigger inpatient stay. So similarly to what we saw for MSPB, we can see that there is a strong impact on the coverage. We're using the current 10-level rule. We have a much larger number of attributed clinicians compared to if we use the more restrictive rule. And that the reliability is in fact slightly higher at the 10-30% rule than the 10 MPI rule. And we see this for both of the example episode groups that we have here, PD and the psychosis measure. Next slide, please. So I'll just quickly walk through some of the resources that will be available so that we have some time for questions. These will be available on the MACRA feedback page in the coming months, and we'll include the measure specifications, which have been updated after field testing, and provide some documentation from the Person and Family Committee, including the guiding principles document, which outlines some high-level principles in terms of prioritizing episode groups for development. We'll also post an updated national summary data report, which is updated after field testing, as well as a summary of the field testing feedback that we received. Next slide, please. So we are currently in a nomination period for Wave 3 of measure development. We're convening committees. So for the first time, we're convening a chronic condition subcommittee, as well as 3 for developing acute and procedural measures. These are dermatologic disease management, general and colorectal surgery, and hospital medicine. So the process that we'll follow is similar to what we did in Wave 2, where we'll have a broader CS who will help select the episode groups for development, and then also provide input on the composition of a smaller work group who will go through the process and provide very detailed input to build out each aspect of the measure. Next slide, please. So the main things that I wanted to highlight on this slide is just the framework for episode-based cost measure development, and carrying over some of the key principles that we've heard from our technical expert panel as well as stakeholders throughout the measure development process. For example, the importance of clear attribution, the need for measures to be designed so that they provide feedback to clinicians about their cost measure performance that allows them to improve their care practices, accounting for patient factors outside of clinician control, and the importance of aligning with quality measures as they can capture dimensions of care that cost measures cannot. At the same time, we understand that developing chronic conditions, episode-based cost measures, will involve some different considerations, and this is where the TEP has provided some guidance to us, and that we're confident that the chronic condition clinical subcommittee will be able to work through these issues as well as the work groups when they develop the specific measures. Next slide, please. So finally, these are just the links to where you can find more information about Wave 3. The call for nominations is currently open, and we also have a link for signing up to a mailing list if you just generally like to be kept up to date about any measure development opportunities. With that, I think we can open it up to questions, so I'll hand back to CMS, please.
We are now going to start the Q&A portion of the webinar. You can ask questions via chat or phone. To ask questions via phone, dial 1-866-452-7887. Again, the telephone number to dial is 1-866-452-7887. If prompted, please enter ID number 1391935. Once you have joined the conference, please press star 1 on your telephone keypad to ask a question. Again, that is star 1 on your telephone keypad to ask a question. We'll pause for just a moment. Again, if you would like to ask a question, please press star, then the number 1 on your telephone keypad. There are no questions in queue at this time. You may proceed.
Okay, so we'll read one of the questions from the chat. This came in from us, or into us. So we are a large orthopedic group that utilizes both PAs and NPs. So even though our orthopedic physicians are excluded from TPCC, it sounds like our mid-levels will not be excluded. Is that correct?
Yeah, this is a question that we've also heard from other stakeholders, and we were concerned about as well, and wanted to look into to make sure that we know that the measure is really targeting the sets of clinician and clinician group practices that we're planning to target with the measure. It is the case that it's possible for a physician assistant or nurse practitioner in a large orthopedic group, for instance, to perform, let's say, 2 primary care E&M services within 90 days, and therefore to be attributed the measure. And if that orthopedic group is reporting as a TIN to MIPS, then the orthopedic group could be attributed the measure through the physician assistants and nurse practitioners. So we wanted to look into this in order to make sure that the instances in which this were happening were rare, and if they were happening, made sense, and were consistent with the intent of the measure. And fortunately, it is the case that it is. To give you a quick sense of the measures, the way this works for TINs, we looked at all TINs, and we looked at what fraction of TINs are attributed to the measure solely based on physician assistants and nurse practitioners, and that's on the order of 15% of TINs, but the majority of those TINs have the most common specialty being physician assistants or nurse practitioners. And so the type of case that you bring up is an important one, but it's rare, and in the rare cases where a group would be attributed the measure, it would have to be the case that the physician assistants and nurse practitioners were substantially involved in primary care and had a confirming event. We look to make sure that in general the involvement in primary care is high for anyone who has a confirming event, and the shares of E&Ms, if you restrict to specialties that are not excluded from the measure, the shares of E&Ms that are accounted for by any clinicians that have a confirming event are quite high, on average over 50%.
Stephanie, do we have any questions from the line?
There are no questions in queue at this time.
Okay, so another question that we're going to read out loud. What is the practical impact of the MAP not supporting the TPCC revisions? Does this mean it's unlikely these revisions will find their way into the proposed rule?
Thank you for the question. My name is Joel Andrus. I'm with CMS as the measure lead, as I stated earlier. So the practical implications of the MAPS conclusions doesn't necessarily bar CMS from proposing a measure, but it does present us with a requirement to provide a strong rationale for why we would propose the measure in spite of the MAPS recommendations. So as a practical matter, it could still potentially go into a proposed rule, but the burden would be upon CMS at that time to justify why it is doing so. And of course, that proposal would then be subject to the public comment cycle as would any measures that we proposed within the rule. Thank you.
Okay, our next question, will the revised measures be used in 2019 performance period?
Again, thank you. This is Joel again. To be clear, none of the measures or revisions to measures that we've discussed on this presentation will affect the 2019 performance period. The purpose of this webinar is not to give you an update on the program, on the MIPS program, but rather an update on cost measures that we are developing that may be considered for the MIPS program within the future. And so none of these will have an impact on the 2019 performance period. And in fact, before any of them can have an impact on the MIPS program at all, they would have to be proposed individually within through the standard rulemaking cycle. And until that occurs, they will not be a part of the MIPS cost category. Thank you.
Again, to ask an audio question, please press star, then the number 1 on your telephone keypad.
Okay, our next question also comes from the chat. Can you clarify what your mean reliability statistics measure for the EBCMs? Are they measuring whether attribution was conducted reliably, parentheses, that is, the true provider of service was correctly attributed?
Sure. This is Sri Nagavarapu from Acumen. The reliability statistic measures the fraction of the variance in a clinician's cost measure that's accounted for by differences between clinicians rather than just statistical noise within a clinician. So the way to think about it is every clinician is attributed a set of episodes. There's going to be some differences in costs between those episodes within any clinician. And a reliable measure, a measure with high reliability under the statistics that we showed, is a measure that tends to identify systematic differences between clinicians as opposed to wide variation in costs that occur within a clinician that may just be random variation across the episodes that are attributed to a clinician. To get at the second part of your question about whether they're measuring whether attribution was conducted reliably, I would say that they don't directly measure that. What they do, however, that is related to your question is they assess whether or not the measure is identifying something systematic about the performance of the attributed clinician. So to the extent that if attribution were happening in a very haphazard way, in a way that would generate really wide variation in the cost that any given clinician sees, that sort of swamps anything systematic about the performance differences between one clinician versus another, then reliability would look low. And so to this extent, the reliability statistics are helping to speak to the type of concern that you have there, even if they don't capture that directly in a statistical manner.
There are no audio questions at this time.
Okay, from the chat, from Denise Lerner, will there be cost measures available to diagnostic radiology in the future?
This is Sri Nagavarapu from Acumen. This is something that we've been working closely with CMS with, as well as gauging interest in particular clinical areas for new types of measures. I know in Wave 3 that Joyce and Joel talked about, we've made decisions about which clinical areas to move to next, partly based on the feedback that we've gotten in Waves 1 and 2 and the enthusiasm from certain specialty societies or other areas or clinician representatives to the subcommittees about developing a cost measure in a particular area. And so this is something we could definitely take into account. If there's an interest in developing cost measures in the future for diagnostic radiology, I definitely encourage you to reach out to Acumen through the email address shared in the slides, or to CMS through the QPP help desk, and that's something we can definitely factor in for the future, even though in Wave 3 there's not something specific to diagnostic radiology.
Our last question that we'll be answering today comes from Ann Clancy. Are Maryland hospitals and critical access hospitals excluded from MSPB?
Yep, this is Sri from Acumen again. Maryland hospitals are included in the MSPB clinician measure, but CAUs are not included as a trigger admission for the MSPB measure. Now, if the MSPB measure is a measure that, like these other measures that you're seeing, include costs over a set period of time, both the trigger admission, also called the index admission, as well as costs that happen in the post-discharge period. And if there is an inpatient admission from a CAU that happens in the post-discharge period, then that would be counted as a cost in the MSPB episodes. But an admission at a CAU will not trigger or start its own MSPB episode.
Okay, so for anyone that has asked us a question, we will, even though we may not have gotten to it on the call, we will reach out to those of you who have asked us a question to make sure that we can answer your questions. Stephanie, you can now close the call.
Thank you. This concludes the Q&A portion of today's conference call. You may now disconnect.